Thank you so much. And so we're going to be taking a turn to a very different population from the last two that were discussed, and I'm going to share our experience in San Francisco. And I just wanted to point out that I'm going to be presenting citywide data for the most part, but our epidemic is very different not only from the last two presentations, but also from the overall epidemic in the United States, in which 92% of our population who are living with HIV are men, and almost all of them are either men who have sex with men or men who have sex with men who also inject drugs. So this is a cartoon version of what we believe has been happening with new infections in San Francisco. There was this early dramatic rise in numbers of new infections, a fall that was due in part to behavior change and unfortunately in part due to a fairly rapid death rate. We leveled out in the late 80s, early 90s, introduction of antiretroviral treatment, and we believe that there may have been a slight resurgence in the number of new infections, and we think we're on a downward trend. So I'm going to talk you through why we think these things have happened. Once highly active antiretroviral therapy came into effect, we saw this really dramatic increase in the number of men who have sex with men who are HIV positive who are on treatment. But what you'll see is that so we went from no coverage to 50% coverage with antiretrovirals at that point in time, but we also then obviously saw a reduced death rate, which was a very good thing. That's shown in the red here, but also then a larger population living with HIV who were also quite a bit healthier. We did see a substantial rise in condomless anal sex, as well as an increase in sexually transmitted infections. And so we think that if we were to look at the drivers of new infections, that increased uptake of antiretroviral therapy really drove down the rate of new infections, but that was counterbalanced by a larger population living with HIV, increased rates of STIs, and increased condomless sex and number of partners. And so we may have had a counterbalancing effect to the positive effects of treatment as prevention because of these other measures. Now, this is what's happened in more recent years. In the last 8 years or so, we've seen a steady decline in the number of new diagnoses. And so this is not a cartoon version, but rather an actual measured result. This is also the reduction in the number of deaths in people who are living with HIV, with a very small, slight but steady increase in the number of people living with HIV. So why are we now seeing this downward trend? And this was the balancing act that we saw before, and we believe that that's been circumvented now by an increase along all aspects of that cascade. We have increased HIV testing and knowledge of serostatus. Not only do we have increased uptake and coverage of antiretroviral therapy, but we have more potent drugs that are starting earlier in individuals' HIV infection course, and then we're improving our linkage and retention. But I would go back to what Carlos said, which is I think that this issue of retention and care is really where we have our greatest need. And so if you look at all of the new diagnoses, and these are shown from left to right, from green to pink, from 2009 to 2012, so this is over a 4-year period, you can see that we have very high rates of linkage to care within San Francisco, 90% in 2012. Retention, though, is a substantial drop-off if you look at 3 to 6 months, and then if you look at 6 to 12 months, we're only retaining still about half of those individuals in care, and so that's a real problem. We are seeing, this is the independent group of viral suppression. We believe that about 2/3 of individuals who were infected, for instance, in 2012, or were diagnosed in 2012, achieved viral suppression at their last viral load test, but that's not taking into account that people then drop out of care and we may not have a viral load test on them. So what I'm going to do is talk you through now 4 stages of the cascade, from HIV infection to diagnosis, from diagnosis to care, from care to treatment, and from treatment to suppression, and look at how are we doing in each of those areas, what are we doing in each of those areas, and what do we have left to do. So we integrated some structural interventions as well in the 2000s. Probably one of the biggest ones was to remove the requirement for a separate informed consent process for HIV testing, and started to treat it like any other infectious disease or other disease in which we do HIV testing, and we explain to patients that we recommend an HIV test, inform them but not require that they sign a separate consent form. And what you can see is that there was this really dramatic increase just in May 2006, just with the implementation of this single measure at San Francisco General Hospital, with an increase not only in the number, so we shifted upward, but also in the slope in which we were doing HIV testing, and the blue are men and the green are women. And we saw we were identifying more of the HIV positives with these tests, so a 6-fold increase in the number of HIV positives, but also we were reaching some of the populations that have been traditionally most difficult to reach: men, homeless, and uninsured. We also made a big push to increase rates of testing in the city, and the 2010 goal was to achieve 30,000 tests by 2014. We've already achieved that number of new tests. And what we can see from the NHBS survey of MSM in San Francisco, we have surveys in 2004, 2008, and 2011, that the proportion of men who have sex with men who have been tested in the last 6 months has increased from 44 to 58%. And that really the substantial issue that we need to address, which we're doing much better in, is what proportion of people who are HIV infected are aware of their infection status. And we've gone from 22% to 7.5%. And we believe that throughout the city, fewer than 7% of our HIV infected individuals are unaware of their infection. So we feel like that we're doing much better in, and we've got another indicator that we're diagnosing people earlier, and that the median CD4 count at the time of diagnosis has increased. The second stage, though, is getting from diagnosis to care, and we needed to do a lot of work in this area. This is just 2 of the programs that have been implemented in the city. One is called FAST, which is a program based at San Francisco General Hospital, launched in 2002. It's an interdisciplinary team that combines both clinical care and psychosocial support services, which are so critical for individuals, both getting them into care and retaining in care. And they've both increased testing and linkage to care at San Francisco General. LINKS is a citywide program that is going to all newly diagnosed individuals, doing partner services, so partner disclosure services, getting partners in for testing, as well as linking people to care, and then focusing on case management on those who are hardest to retain in care. So these are data from 2008 to 2010, and over that period of time, we had about 85% were linked to care within 3 months. We're now at 89% care as of 2012. But you can see that there's still groups that we're reaching to a lesser extent. Those without identified risk. These are men who have sex with men who also inject drugs, the Latino population, as well as those in other racial ethnic categories, and younger individuals. So we still have work to do in getting individuals linked to care, but we're still doing relatively well there. Getting people from care to treatment. The biggest intervention that we implemented really was in 2010, where the city made a recommendation that all patients, regardless of HIV, regardless of CD4 count, regardless of viral load, if they're HIV positive, that they be offered care immediately. Doesn't mean that they had to take care immediately, but we were encouraging people to be treated immediately, because we do see HIV infection as a chronic infection as well as a chronic inflammatory disease, and in the same way that we treat many other diseases, we don't wait till somebody develops the complications of diabetes. We treat them at an early stage. We do implement behavioral changes as well, but we do believe that we have very effective medical treatments that are important to implement. And so if you look at, by year of diagnosis, how long did it take on average to get people onto antiretroviral therapy? This is the number of months. This is the proportion on antiretroviral therapy. And what you can see is that from the 2007 to 2011, going from right to left, we now have a larger proportion of people at the CD4 counts of over 500, of 351 to 500, and even of those over 200, we've been slowly decreasing the median time to initiation of antiretroviral therapy, such that in the over 500, we went from 38 months median initiation to time from diagnosis to initiation of therapy to now 8 months. So we really are getting a much larger proportion of individuals on treatment. When we try to figure out what proportion of people who are living with HIV in San Francisco are being treated, we run into the same issues that all of these surveillance activities run into, which is that we don't necessarily know. So we have a low estimate and a high estimate. The low estimate is of all people who are not known to be dead, who were diagnosed in San Francisco. But that's going to underestimate the proportion on antiretroviral therapy because some of those people have moved. We look at the upper level estimate, and that's of all the people who are in care, who we've been able to do a chart review on in the last 2 years. What proportion of them are on antiretroviral therapy? That's an overestimate because, of course, we're not including people who are no longer in care. But we believe that we're in the mid to high 80s in terms of the proportion of patients who are receiving antiretroviral therapy, and by receiving I mean it's been prescribed for them, but taking it and adherence is a different matter. And what I've highlighted in red are those areas where we still have more work to do, where the rates are somewhat lower. Women, people of color, injection drug users and heterosexuals, and particularly the homeless and those who are uninsured. So then let's talk about treatment to viral suppression. And again, what you can see is this is going now, this is a much bigger graph so you can read it a little more easily. From 2005, and this is data that came in 2009, so we didn't have complete data, but 2005 to 2009, the median time to virologic suppression now has gone from 32 months to 10 months. So again, we're getting people into care, getting them on treatment and getting them virally suppressed for a longer period of time, but we still again have some disparities. And the disparities here are in younger individuals, in the homeless, and in those again who aren't retained in care, which is not a surprise. So what impact has all of this push on the cascade done in San Francisco to rates of new infections? As I said, the number of the infection is largely an MSM epidemic. It's MSM and MSM IDUs, and you can see that we've had a substantial reduction in the number of new diagnoses, despite this push for an increased number of HIV tests. So we believe that this does reflect a reduction in new infections. When we look at this by age, we see that we've had the biggest impact in the 30-year, the individuals in their 30s. What we're most concerned about right now really is this group of the 18 to 29-year-olds, where we've remained pretty level over this period of time, and they now nominally are the group with the largest number of new infections, and they're the ones that are less likely to both get into care and be retained in care. So that's a group that we feel that we need to focus on. Now, San Francisco also has a population that in which there's been a large out-migration of African Americans, but we still see that if you look at the rate per 100,000 population, that African Americans have the largest disproportionate impact of HIV infection among men. But you can see that we are still reducing infections in both in African Americans and in the white population, perhaps a little bit less in the Latino population, and we've actually seen an increase from 6% of new infections to 12% of new infections in the Asian Pacific Islander community. So that's another group that we think has been under-recognized and needs to be served as well. So let's say that we're now in Prevention 3.0. We've got all of the things that we've done in prevention up until this point, and treatment is prevention, but we still have a gap that's going to be very difficult to close. And we do have new tools to try to prevent new infections, like pre-exposure prophylaxis. And so there's this question that's arisen, yeah, but nobody takes it and the adherence is really poor. These are just data from the first 4 weeks in our demonstration project. We enrolled 300 men in our demonstration project, we had waiting lists of men who were interested in getting pre-exposure prophylaxis. We couldn't serve as many as wanted to get it, and when we look at the 4-week blood levels of tenofovir, we see that virtually all of them were either taking levels consistent with daily use or at least 4 doses a week. So we do believe that we can get individuals onto pre-exposure prophylaxis, and we believe that we can put these things together, and that in order to drive new infections down to 0, we're really going to need to put both treatment and pre-exposure prophylaxis, as well as a host of other interventions into effect. And I just want to thank and acknowledge the many people in the health department who have both helped in providing slides, but who analyze these data and collect these data on a regular basis. Thank you.